Now, you've been looking at male breast cancer, and you've got a very, very big study with a lot of patients in it. Can you tell me what it is that you did?
Indeed. So this is it's called the International Male Breast Cancer Program, and it's a worldwide effort to try to characterize this very rare disease. So male breast cancer accounts for only 1% of all breast cancers, and it's so far we have very little knowledge of the disease, and patients are managed as an extrapolation of female breast cancer.
Okay, can you give me the backstory on just how patients are managed normally, because there aren't enough of them for individual centres to really have a lot of expertise?
No, not only that, but since no prospective randomized study was ever finished because of lack of accrual, we actually do not have solid data on how to manage this disease. And so this program basically is set out to understand the biology of the disease, to understand how we could better manage these patients, and at the same time review what has been done in the last 20 years.
So what did you do?
So for the first part of the program, we had a joint retrospective analysis of all patients treated in the last 20 years in the participating institutions, and we ended up having 1,800 eligible patients. And those patients had to have a tumor block, and that tumor block was centrally assessed. So now we have not just the clinical data centrally collected and analyzed, but also the biology centrally analyzed.
What did you find?
In terms of the clinical data, we found that overall patients have not been, let's say, correctly managed. So not just related to surgery, the vast majority has mastectomy, although about 40-50% have small tumors, but still they do not, there is no tradition of discussing with the patient the possibility of breast-conserving surgery. On the other hand, another very important finding is that although 99% of these tumors are ER positive, only about 77% of patients receive adjuvant endocrine therapy, which is by itself a very important finding, because it means that these patients are not receiving what is assumed to be one of the best treatments for the disease.
So what has been going wrong in the past then?
I believe it's mostly because of being a rare disease, of not existing prospective data, that patients are managed a little bit according to the experience of the oncologist. So with this study, we hope to provide insights on the biology. It also gives us the possibility of analyzing in depth these samples. And at the same time, we have already launched the second part of the program, which is a prospective registry. And we are already developing the third part of the program, which is a randomized trial.
So what insights have you already gained into this disease?
Apart from the clinical part of how the patients have been managed, we realize that now that the male breast cancer is mostly ER positive, PR positive, and also androgen receptor positive disease. Only about 9% have HER2 positive disease, and less than 1% have triple negative disease. Meaning that if an oncologist receives the pathology report of a male patient and it's a triple negative or a HER2 positive, the first thing to do is to rediscuss with the pathologist and make sure that it's really indeed the fact.
It sounds as though there are quite a few therapeutic opportunities offered by that characterization of the tumor then.
Indeed. And so one of them is to certainly can be improved the administration of adjuvant endocrine therapy, and one of the trials that are being already in late stage of developing is using an androgen receptor inhibitor in these patients.
And I think in your study you discovered that, in fact, over the period of the time covered by the study, treatment for male breast cancer has actually improved, or outcomes have improved.
The outcomes have improved, so the overall survival is substantially improved, but that also has to do with the fact that life expectancy in males have improved. The breast cancer specific survival has improved, but much less than what we have seen in this last 20 years for the women. On the other hand, some parts of the treatment have improved. Over the 20 years, more patients are receiving endocrine therapy, more patients are receiving radiation, and however, for example, mastectomy rates have not changed over time.
Right. So what are the clinical messages coming out of this? It sounds as if there is potential. What do you advise doctors to be doing?
So first of all, to be attentive to the biology of the disease, not to forget the importance of adjuvant endocrine therapy in this particular ER-positive disease. For the adjuvant setting, all the data that we have is for the use of tamoxifen. It was a bit disturbing to see that a small percentage, but still a substantial percentage, is receiving aromatase inhibitors alone, and we actually do not know, and the data that we have points for a lower efficacy of these agents. So there are a couple of important messages while we are waiting for randomized data on how to manage these patients.
So if you were to sum up what doctors need to remember from the facts that you discovered in a few words, how would you summarize that?
So discuss with the patient regarding breast-conserving surgery. Albeit we discuss that with women, we don't discuss it with men so often. Don't forget the importance of radiation therapy in these patients that often have node-positive disease. And do not forget adjuvant endocrine therapy with tamoxifen.